There's a few people standing at the back. There's a couple of spaces in the seating if anyone wants to take this moment to sit down ahead of the next session, which I'm really excited to announce. So it's fertility and mental care for everybody, breaking the stigma for more inclusive future. And we have our moderator, who is Lizz Summers, and she is the CMO of Medical Digital. So welcome to the stage, and thank you so much.
Thanks so much. Hello. Nice that the session is nice and busy. Come on in, make yourself comfortable. I'm really excited about this panel discussion today. I think it's a really nice follow-on actually from that great session from Beetroot. So as mentioned, I'm head of brand and marketing at Medico Digital. We're an independent award-winning digital marketing agency, so we do a lot of work both in the women's health space with fertility clinics, Copperfield, etc., but also across other areas of the medical biotech and medical devices space. So we do everything from website design to SEO to content creation to organic and paid social media. And I'm really excited to welcome the speakers to the stage for today's panel. So if you want to come and join me, and I'll introduce maybe once we're seated. Thank you. Let's see if it's like a game show to see if you can sit under your photo. Easier said than done. If you could pop that there, thanks. We didn't quite make it. Tatiana, do you want to swap with me? And I think we'll be nearly there. It's close enough. Thanks. Okay, so our speakers today, I'll just quickly introduce each of you if that's okay. So on the far right, as you're looking at us, we have Tatiana. So Tatiana Klimanova, if I've said that correctly, is head of Acceleration Director at FemTech Labs. Then we have Sarah Henry. Sarah, I'm really excited to have you on board today. Sarah is a race and ethnicity trainer. That's hard to say under pressure. And also a qualified counsellor and published author. And then we have Dr. Helen O'Neill, who is possibly one of the busiest women in the UK right now, hence a bit of a mad dash for the session. We're so grateful for you joining us today, Helen. So Helen, if you don't know, is CEO of Hertility Health. And then we have Bridget Gorham, who is Health Economic Partnerships Lead. Is that the right words in the right order? Great. For NHS Confederation. And you'll find out about a bit more about the speakers as we go through the panel today. So the first question, I suppose, is when we're thinking about women's health, we've seen a really big change in the landscape over the last 5 years or so. Tatiana, can you tell us a little bit about why we're starting to see the shift? Like, how has it come to be that we have a crowded room talking about women's health today?
Absolutely. First of all, I'm so excited to see so many people interested in this panel. And I was at the Giant Health last year. Last year we had one tiny panel. It was probably a quarter of this room. It was tucked away somewhere in the back, and it was just like a couple of chairs. And this year, it's the whole day dedicated to women's health. We have the whole stage. We have an actual stage as opposed to just like somewhere in the corner. So I think in itself, it shows the amazing growth of the sector, and the attention is being brought to the sector, which is absolutely amazing. And I'm super grateful to Giant Health for organizing this important discussion. I think if we think about femtech sector and the rise of it, it's I think it's an inevitable movement that needed to happen. Women play a really influential role in the entire process in healthcare, from as consumers, as caregivers, as professionals, and despite that, there haven't been a lot of investment in women's health, and I think like the increasing concern in the disbalance have brought the need to create more digital solutions in women's health. Hence, kind of femtech rose as a movement. So we now see a lot more digital platforms, liberating discussions about women's health, bringing to all the challenges to the surface, and reducing stigma. So it's really great to see that.
Great, and of course, as the recognition for FemTech as a segment grows, that in itself brings new energy, new creativity, new ideas, new investment to the space, right?
Exactly.
Amazing. And Helen, you obviously are the founder of a really successful startup in women's health. Tell me about your perspective on why we're seeing this big shift in the industry.
I mean, I'd like to say that this is something that, we're grateful for, etc. But actually, it's something that makes me feel a little bit angry. It's more that we should be saying about time. We're 52% of the planet, and up until now, we've been medically sidelined, medically ignored, medically gaslit. And I think that shining a light that is dedicated to women in all of our incredible potential, not just as people, but as people that can create people, it's about time that we started to build that. And from my perspective, I spent a very long time, learning to be an expert in women's health. I spent the last 15 years, in education, essentially, doing an undergrad, a master's, a PhD, a postdoc, lecturing, becoming a lecturer, and teaching all of the things about female reproductive anatomy, physiology, fertility, embryology. And yet, when it came to answering questions for myself about my own health, actually, when you look at the textbooks from a personal perspective, not from an academic, I'm learning this to teach it perspective, you realize that actually the information is very sparse, that the data is incredibly poor, and that our expectations for what is good quality when it compares to studies on women's health is really just not equal. So I think for me it was about taking all of the information that I knew and saying, how can we transcribe, how can we translate, and how can we make this both equitable but available to women in a world where we have access to almost every other triviality. We don't have access to the basic standard of care of health. So I think that's, for me, it's just about time. I don't think it's, I think we've just maybe put up with enough for long enough.
That's amazing, thank you. And this is a bit of an eye roller type of a question maybe, but when we think about women's health, is it just women that should care about women's health? I had a really interesting conversation with somebody recently, a man, who was like, oh yeah, that's really interesting. It's not really my specialist subject, so not that interested. And we experienced this across the board, but is it just women that should be interested in women's health? Bridget?
So I think I'll start by saying no to that, a resounding no to that question, and pointing out that women's health literally affects every single person in this room, whether it's ourselves, our mothers, our sisters, our friends, our colleagues. It's something that needs to be tackled by every single one of us. And I'm a health economist, so I come at this issue from an economic lens, and I'm currently working on a report that shows the relationship between investment in women's health and wider economic growth throughout England. And as I've started on this undertaking, there are some obvious kind of correlations with the number of women that are leaving the work due to the menopause, taking time off work due to the menopause, the amount of days missed every month due to menstrual disorders. But then there are a lot of more nebulous elements to this, which include women's caring responsibilities that aren't measured through normal figures of economic growth like GVA, GDP. There's obviously the NHS element to it, where 80% of the NHS is women, female workers, and if we're not supporting our, if those women aren't healthy, then they can't keep the rest of the population healthy, and then the rest of the population isn't healthy to go to work or, go about their day-to-day lives. So it's really kind of layered topic, but I think it's really important to assess this from a perspective that really kind of drives down the idea that this topic matters to all of us.
Thank you, that's really helpful. And the topic of today's panel is really about, I mentioned fertility and menstrual care, but wider than that, but for everybody. So what does everybody mean? And as part of that question, Sarah, maybe you can start us off with, in a conversation that's fundamentally about gender, about women's health, why is it important that we're also talking about other things? So for example, race, disability, sexuality. So race in particular, given that's your area of expertise.
Thank you. For me, it's vitally important that a person's race and ethnicity is considered in the women's health conversation, and that's fundamentally because we cannot be made up of divisible parts. We live as a whole, and the experience of a black woman, a brown woman, has to be considered. Let me just put this down. Has to be considered in its entirety in order for the healthcare provisions that are being proposed to be effective, to be sustainable, and to ultimately be accessible. So when we consider intersectionality and the separate characteristics that make us who we are, it's the crossover and the compounding nature of that crossover that can have a huge impact on the accessibility, the representation, and the sustainability of the healthcare provisions that are afforded. It's switching from the idea that there is a default of healthcare and there are add-ons afterwards, and rather a consideration of an initial concept of healthcare and a development for the subgroups that need it.
That's really helpful, thank you. And I think sometimes when we think about women, when we're thinking about categories, we can think of women or people of particular characteristics as a homogenous subgroup, right? We think that, if you close your eyes and picture a woman, you have a particular image in mind of a woman that you perceive. But actually, we have to bear in mind, right, that there are all different types of women from all different types of backgrounds, with all different types of life experience, with all different types of biology, and that layered experience is a really interesting component, right? We can't just look at the experience of white middle-class women. We also have to think about how that experience is different. And Dr. Helen, you've done a lot of work, obviously, in the inequality report. Maybe you could just share with us a couple of the key findings from that report.
Sure. So when we built Hertility, we wanted to build a health assessment that took into account the individual risks. And essentially what we were trying to build was a predictive algorithms for certain gynecological pathologies. And what that means is taking into account all of your symptoms, all your menstrual factors, your previous medical history, but also what is your ethnicity. We know that people from different backgrounds have different risk factors for certain pathologies. And so factoring that into our health assessment meant we could effectively triage women to say, okay, maybe pelvic pain in one is actually going to be of a higher risk for one individual than another. We know that black women are more prone to fibroids, and so if we notice heavy menstrual bleeding and pelvic pain, we're going to say, really, we recommend you get a pelvic ultrasound scan. We need you to get to care sooner. And so building that in, and equally, the age of onset of perimenopause is 4 years earlier if you're South Asian in origin. So if you're starting to display symptoms of perimenopause, we need to take you seriously rather than taking you into account for the generalized statistic of 51. So if you're in your earlier 40s, maybe we should actually listen to you a bit sooner. And this is the problem. Women do not get listened to because we look at generalized statistics and hope that everyone falls within those categories. So when we wanted to take into account as many different subgroups of populations and ethnicities into our health assessment, equally the different risk factors for different pathologies. And then what we wanted to look at was, what were the risk factors or what were the health behaviors that people undertook? Because even though we can try and assign different risk factors to get people to help sooner, actually people's personal behaviors as a result of their backgrounds can be actually quite different. So we saw this when we wanted to publish our findings. So we created two reports. One is the reproductive report, which just shows essentially that we are not the textbook woman. Take, for example, this 28-day cycle, that every woman has a 28-day cycle and therefore ovulates on day 14. 70% of women do not have a 28-day cycle, and therefore, this idea that you need to time your pregnancy on day 14 is not going to work for you. But the second report we did was called the Inequality Report, looking at really launching a Black Women's Health Initiative to say, why is it that Black women suffer poorer outcomes? Why is it that they approach fertility services later? And the Human Fertilization and Embryology Authority published a statistic showing that Black women tend to be older and try to conceive for longer before they go for fertility treatment. And we thought, in the absence of that barrier, which is physically going to a clinic, where we have an at-home diagnostic test, do we still witness the same health behaviors? And we do. On average, white women are 32 years old and are trying to conceive for 2 years before they turn to fertility. Black women are on average 37 years old and try to conceive for 4 to 5 years before they reach that. So for us, this signals a need to approach people different, to use language that is different, to reach people on a different level. We have to work harder to try and reach people in different formats, because otherwise people get left behind. And I think that is part of it. We can try and build models in medically, but we also have to build in protective models socially to try and reach people.
That's really helpful, thank you. And obviously we have a little bit of representation on the panel today. Sarah, obviously you're a black woman, I'm a member of the LGBTQ community, so we come to it with maybe a slightly more nuanced sense of the types of barriers or challenges. You know, when we talk about IVF, often we're thinking about heterosexual couples pursuing IVF and aren't thinking about the barriers that exist for same-sex couples. But why is it important? Obviously, we are all able-bodied people who were able to come to the session today. There's nobody, as far as I know, with a physical disability on the panel today. Why do we really need to be looking at not just the people who are already in the conversation, but the wider population of women that exist, and particularly those who maybe are more hidden, who maybe can't participate in things like this, aren't able to make it to the event today, are from, you know, communities where being part of this movement forward is more difficult? And how do we reach those people to get their perspective? Bridget, have you got anything to add there?
Yeah, I think our policies, whatever we do at the end of the day, they all need to be reflective of the populations that they're intended to serve. And so if we're not actively seeking out individuals from diverse backgrounds, then our policies innately are not going to serve those people. And in my experience, I think a range of kind of mechanisms are needed to, whether it's, you know, digital surveys, in-person focus groups, talks like this, but also going out into communities and actually meeting people where they're at, employing a range of different kind of approaches to ensuring that we're meeting as many people that we possibly can, as we're tackling some of these topics. And it's really interesting, for example, the menopause. I know that word doesn't even exist in a multitude of languages. So think about those types of barriers, cultural barriers, language barriers, etc. So it's important whenever we go out to tackle these issues that before we do anything, we kind of put it through this health equity lens to ensure that everyone, or as many people as possible, can be captured through these initiatives.
That's really helpful, thank you. And when we're talking about women's health, quite often we are thinking about menstruation, fertility, menopause, but of course there's a lot more to it, right? There are numerous conditions where the outcomes are poorer for women than they are for men. For example, autoimmune conditions which disproportionately affect women, migraine which affects 3 times as many women as it does men. You know, we've seen in the last 40 years or so the rates of lung cancer in men have reduced by 43% and increased in women by 79%. And so we see actually there are a number of other differences in men's versus women's healthcare that are not just about having a uterus. What is that, and how can we be more expansive or inclusive when we think about women's health so that men can be more interested and feel a bit less like they're standing awkwardly in the bra section at M&S? Bridget, could you?
Yeah, it's a really good question. And you mentioned autoimmune diseases, lung cancer. There are a whole host of like cardiovascular disease. There are a whole host of conditions that disproportionately affect women or affect men and women differently that we're not aware of or perhaps don't have enough research on just yet. So I think there are a whole host of kind of pillars to answer this question. The first thing I would say is that men can certainly be a part of conversations around periods and the menopause and all of those kind of like quintessential, air quotes, women's health issues, because they do matter. But I think perhaps the more pernicious ones are the ones that you've mentioned, because I guess oftentimes I'm confronted by the attitude that, well, we already have a lot of research on this condition, or it's very well understood. But perhaps it's very well researched and understood from a heteronormative kind of male body lens and not from the lens of a woman's body, and that needs to change. So again, I guess this kind of couples into my previous answer that everything we do needs to be from an inclusive health equity lens that accounts for a multitude of bodies, genders, races, ethnicities, ability, etc., to ensure that everything we do, from research to services to innovation, encompasses kind of the whole society that it's intending to serve.
That's really helpful. And Sarah, I'm going to come to you next. So when we're thinking about trying to create a more equitable future and having some of the discussions or moving things in the right direction, one of the things that people tend to say most commonly is that they're worried that getting involved in a conversation about the inequalities that exist or the way that different subgroups experience things, they kind of feel a bit awkward about getting involved in it, particularly if they aren't women or don't come from one of those subgroups. And one of the things they tend to say they're most worried about is kind of tokenism or virtue signalling. Like, for example, if we write about women's health, or if we write about some of the inequalities that exist for women or for people from subgroups, is it just that we're like doing it to look good? Is it like the whole hashtag Black Lives Matter movement where there was this maybe question about how authentic people were being in getting involved in that conversation? Do you have the solution? Do you have any advice? Do you have any kind of tips for those of us who maybe want to move things in the right direction, but people who are nervous about saying and doing the wrong thing?
Yeah, one of the key points and key words that I heard there from you, Liz, was authenticity. And for me to be authentic right now, I will offer to you and to everyone here that my experience is that concern is one that predominantly lives in white people and not the black and brown people that I personally engage with. And so one of the things that I want to make really, really clear about that is, for me, when there's a concern about tokenism or virtue signalling, it's about if you want to do good or to look good. And by that, from an ethical point of view and your own morality, is the greater concern about how you are seen by other people, or authentically what it is that your moral compass is driving you to achieve. From my own lived experience, like I said, virtue signalling and tokenism isn't something I have been concerned about. But in talking to some of my white colleagues, friends and family, it feels like such a phenomenal barrier to be able to authentically make a difference and to reach the people that I am told are important. So it's not only about considering whether it's about doing good or looking good, but also about that self-inquiry and what is it about the tokenism that is driving you to behave in a certain way? What are those barriers for you individually? And what that actually does is it shifts the viewpoint from what is happening out there in the world to what is happening in here for each of us, because that is the only part of this conversation that we truly have access to. The endeavour to change the world is admirable, but is it actually too ambitious? If we shift our individual mindsets as to what these barriers are and courageously interrogate ourselves rather than the other, what it means is that the good can be done, and it doesn't matter how it looks, because it's the fundamental belief that's driving rather than sitting on the right side of a politically correct fence.
That's really helpful. And of course, people tend to be quite worried about terminology. We know that terminology evolves over time. So, for example, we might use black and brown people now that we didn't use that phrase before. There's a thing in my parents' generation about whether or not you can still say coloured. No, I have let them know. But people are worried about, using the right terminology, getting something wrong. It happens a lot in the LGBTQ community where people are like, oh, lol, how many letters are there now in the acronym? Haha. Tell me about, how can people manage their own fear about getting it wrong? Or are there solutions to help them be less likely to get it wrong?
The fundamental solution is admitting, as far as my own professional stances, it's well and good to be frightened, but the problem doesn't shift through fear, and actually what happens is we become more polarized in our differences if what we're driven by is the fear of offending. So for me, it's rather than thinking, oh, I mustn't use this certain terminology, I'm frightened of using this terminology. Again, it's about owning that fear. And then from that, you are able to have a conversation with somebody that you truly view as equal, and not somebody that society said you should view as equal, but you yourself has positioned them as superior or inferior. I wish I had a glossary of the perfect terms, but living in 2023, those terms are just ever evolving. And I am only knowledgeable from lived experience when it comes to the race and ethnicity conversation. So Liz, we've had professional conversations, and for me that's what it's about. I don't know everything, and I don't believe I should know everything, but everyone in this space is wanting to make waves in the women's health space. That's the unifying factor for all of us. The differences are where our knowledge base lies, but the actual drive and the change that is wanted is one of equality. So the acceptance of ourselves and our fears, which is, it's a tough gig, but people have read the podcasts. I'm sure you've read the books, you've watched the films, you've watched the suggested Netflix series, and there's still more that stops each and every one of us from overcoming that barrier. So self-inquiry and owning the fear of the conversation is how the conversation becomes less frightening overall.
Yeah, and of course, being able to be curious, be able to be wrong, be able to ask the question about what's okay and what's not okay, and being willing to take part in that. I think one of the things that can happen when we're worried about getting it wrong is that we can just avoid going anywhere near any perceived danger zone, right? We're like, okay, well, if we put out this content which talks about inequalities, what if we don't get the tone quite right, and maybe then that will get a backlash? So the safest things to do is say nothing. But of course, saying nothing is also saying something, right? So in addition to this, Helen, what do you see as some of the challenges in moving things forward, and how does that balance with the opportunities we have? So I guess, what stops innovation in this space, and then what's happening to move it forward? And then I'm going to go to Tatiana.
I think the biggest barrier everyone faces is funding. Like, there's just such a discrepancy between the amount and the allocation of funding towards women's health, towards female founders, and it's not evidence-based, despite the fact that female-led companies outperform male-led companies, that diversely led companies outperform non-diverse companies, there is still this systemic infringement of women's health needs, of women's health funding, and of a lack, this systemic disparity. We see this through the gender pay gap. Why is it that, I may as well not work for the rest of the year for what I will be paid compared to my male counterparts? Probably, actually, I should have started that in August, because the gender pay gap is so huge between men and women, and the same is true when it comes to allocation of funding. We just do not see, I gave a pitch to a room full of investors, and somebody afterwards said, oh, the man with the grey hair wants to follow up with you afterwards. And I went, sorry, everyone there was a man with grey hair. So I think you might have to clarify. In a room full of people, there was one woman. And that is where we just don't see the opportunity, because there's not that same level of genuine understanding. I find it so patent when I pitch to a male investor versus a female investor, and it's not about male versus female, but the instant understanding about what we're doing, the instant appreciation, respect, and actually, just genuine desire to say, oh my God, this is amazing, I wish this had been around, versus, oh, okay, so in terms of the market, and they're going, okay, we have to go down to the market level, which is 50% of the planet. I don't know, I think until we start to allocate proper resources and funding into one of the biggest opportunities there is, we won't really see a change. What we'll continue to see is tokenization and, annoyingly, panels that discuss the opportunity. Why should men care? And the same arguments about why we should be grateful to be here talking about this revolution. And in fact, it should have happened a long time ago. And unless and until we start to really discuss just the inequalities in terms of all of the, we time and time again hear about women weren't included in clinical trials until 1993. How gobsmacking. But actually, you think that change happened in 1993. In 1993, the FDA made a suggestion that maybe pharmaceutical companies should include some women in their trials. There is still no emphasis on disclosing from pharmaceutical companies how many women have been included in their clinical trials. In fact, the last 27 clinical trials by an unnamed major pharmaceutical company included 27 women total. So we're still not there. It's just that we think we are because we're talking about it more.
Yeah, that's here. Great. And Tatiana, what are you seeing in the FemTech lab? Because of course, when we think about investors, I mean, people have been investing for a long time in things that don't directly affect their body, right? It's not new for an investor to invest in something that they personally will not benefit from. How are we seeing that play out in the FemTech space?
I feel Helen's pain. We have over 70 startups in our portfolio now as FemTech Lab, and every single one of them goes through similar challenges. Yet, as an accelerator, we are accelerating the field. I have to remain as a hopeless romantic, and again, bring us back to the point that, yes, all these challenges exist, but still it's important to recognize the growth that we have gone through, and it is happening. It's happening slower than it should be. It should have happened 30 years ago, but unfortunately, it is what it is. But if we look back, so Silicon Valley Bank posted a great report, and looking at the progress in women's health, so last year has been devastating, or this year, I mean, devastating in terms of investment in healthcare in general. In women's healthcare, seeing a massive freeze in investment. It's projected to kind of remain, but still, if we look at the last 5 years, from 2018 to now, the investment in women's healthcare have grown 300%. Mind, the base was different, but 300% growth versus 15% growth for healthcare in general. So it is happening, and we see the sector grow. We see our investors. We have over 400 investors that working closely with FemTech Lab. They come to our demo days where we just celebrated the graduation of our 6th cohort. We had over 120 investors registered, and about 60 of them attended the demo day. So there is a kind of a growing interest in the field. Mind not as quick as we hoped for, but yeah, we see, and I think we, as FemTech Lab, we started 3 years ago, and since then, we, from cohort to cohort, we run 2 cohorts a year. So this was our 6th cohort. Over 70 startups in the portfolio. Like I said, we see an increase in not only in the quantity of applications to each cohort, but also the increase of the broadness of solutions. So it used to be very heavy menstrual health and fertility. We now see, and also in the kind of investor mindset, we see a recognition that women's health is not just about bringing babies. Not all women will have a child, but all women will go through menopause. So we see more solutions across menopause, across mental health, and also what's exciting is that it's becoming less fragmented. So we see less point solutions, and just like Hertility itself, fantastic to see. It's a whole platform catering to a very kind of diverse needs of women, of a woman going through life. And I think that's what we start seeing a lot more kind of holistic approaches. So, for example, menstrual health and mental health is becoming a kind of more interlined. So those intersectional solutions is a big step forward for women's health as well.
Thank you. And obviously, I'm from Medico Digital. We're a digital marketing agency. There will always be a question about marketing because it's my geek subject. Helen, when we think about the role of marketing in helping move this conversation forward, in helping break some of the stigma, in help actually facilitate some of the innovation that we want to see in women's health and need to see in women's health, What's your take on the role that marketing plays to actually get this out there in the space? Like, marketing right is just putting the right things in front of the right people in the right way through the right channels. So how do we actually use that to move things forward? How have Hertility approached that? Because I know that you've done some amazing stuff in stigma-breaking campaigns. It's been quite impressive to watch.
Thank you. I think for us, it was about speaking to women on a level. It was about speaking in the language that someone would speak to their best friend, if their best friend might be a gynecologist. And I think really treating women as intellectuals, because we are, and we all have access to information at our fingertips, and being able to channel that, but also with a little bit of humor, because at the end of the day, you know, while you can't be overly trivial about things, this is a subject that we have been mocked for forever, hence our Oh So Hormonal campaign, like saying, yeah, I am hormonal, everyone is hormonal, but using it as a weapon against me isn't going to work. And I think for us as well, we did some campaigns that wanted to get the eyes of everyone. So when we did a billboard saying the Fempire strikes back, we knew that might get a few of the male nerds on board as well. Not saying you have to be a nerd to but yeah, I think it's about being catchy. So many of the, especially when it comes to fertility, and you go to almost every single fertility clinic is guilty of this. You walk in and you see huge pictures of babies, and you just think, what is the worst thing you could show someone who's actively trying and struggling to conceive are pictures of babies. They want hope, yes, but they don't want that constant reminder. And it's actually quite a delicate balance to play, both in terms of visuals, in terms of wording, and in terms of how you convey a message without offending. We are a very easily offended generation. You are always going to annoy somebody. But for us, it was about grounding ourselves in truth, and that to me is about real anatomy, and saying, right, okay, if we can build a brand that shows real bodies, skin, anatomy everywhere. We literally took out our anatomy books and got all of the beautiful reproductive organs that we have, whether it's breast anatomy, uterus, ovaries, and we have them overlaid on all of our, you know, real skin bodies. It starts to weave in, even if it's subtle, that you have an incredible reproductive system in your body. Here is where it sits. You have an amazing uterus with these ovaries that are constantly working for you, irrespective of a desire to have children. You know, these hormones control every part of our lives and continue to do so. And that, to me, was about how do we educate women at the same time as bringing them in, at the same time as, you know, talking to them on an equal intellectual level. We're not being overly clinical in it. I mean, we actually go through phases where I'm like, we're too funny, take it back. Let's be much more serious, because people don't realize that we are scientists, we're a team of clinicians, that we're a team of people who are dedicated through clinical trials, because our visual branding is quite, you know, pleasing and light, and then we have to say, okay, let's bring it back and make people know that we're actually quite a serious scientific and clinical entities. But it's something that it's a dance, really.
100%, and that's what we see with a lot of our clients. It's like, how do we talk about this serious subject, but in a way that engages people, but we don't make it too trivial, and walking that balance, trying to find the right message that will connect with people. Like, I think we've seen on this panel, it's this balance around having the appropriate amount of rage about the subject, but also being able to channel it in a way that has some solutions for how we can move it
productive
forward.
rage.
Productive rage,
Yeah.
I love that phrase. So we're going to open to the floor, actually, for a couple of questions just before we wrap up. So did anybody have any questions for the panel? Yeah. Could you? Yeah.
Hi, first of all, I just want to say that was an absolutely amazing speech, especially coming from someone who is a young person. I just felt that really kind of opened up a whole discussion about, you know, what is happening currently in the women's healthcare system, especially considering since that you don't really hear that much. Like that information is not really like handed out to us. We have to rather like search for it. And I feel like you've kind of opened up the fact that how much it's a prevalent problem in the in current society. So I just wanted to ask, so towards the beginning, you kind of mentioned the importance of the women's healthcare in account towards men as well. So as a young person, I wanted to ask if a factor of people stereotyping that only women should care about women's healthcare may be onset and rooted towards the lack of information provided to both genders when they are young. So for example, the controversy of the age, which information should be provided in sex education. So as someone who's still in school, so I'm in sixth form at the moment, I've seen like a prevalent difference between the information a girl has, like in comparison to boys. So I just wanted to ask, how can we ideally like incorporate like the proper information in the education system, considering that I feel like the last time someone properly talked to me about what's happening at the moment within the women's healthcare system was probably like, what, 5 years ago, probably at the beginning of year 7. I haven't heard anything from like people within school. Like we have so much PSHE lessons. Where's the information about women's healthcare?
Yeah, well, I think I'll answer first if that's okay, and then just hand over to the panel. I think one of the things that is most interesting is that historically women's health, and particularly stuff around menstruation, I think has had this big stigma of like, oh, this is awkward to talk about, oh, we shouldn't. And this is something that we've seen in advertising, right? Like if you think about tampon adverts 20 years ago, it was all like woman roller skating in a unitard. You never see blood on the TV, right? Menstrual blood, like it's not really a thing. It's started to become slightly a tiny bit of a thing. Particularly, obviously, there's been this realization that products haven't even been tested on actual blood. And so I think part of it is just this sense that what women go through, Helen, I really loved what you said about it being an amazing thing, right? Because we've kind of been conditioned to think it's like, oh, a bad thing. A bad thing happens to me once a month and I should probably hide from the world, but apparently I still have to go to work. And that point about it being shameful is, I think, one of the barriers in talking about it, right? Men are like, if you ask me to go to the shop and buy sanitary towels, I will quite gladly get run over on the way there. And it's this thing where we don't talk about it, whereas you wouldn't have that about saying you've got a toothache or a stomachache or whatever else, right? It's this weird thing that we have not been talking about. And now that we're trying to talk about it, everyone's like, oh, well, this is awkward. Helen, do you have any comments on that and why we aren't able to better prepare people for a conversation about this in the real world?
I think when it comes to sexual education and reproductive health, we over-sexualize it. And I think that's our misgiving. So I have a 4-year-old daughter who would correct my partner when he said, Mummy grew you in her tummy. She's like, no, Daddy, her uterus. And I don't see why that should be so strange when we teach kids all sorts of useless information like dinosaurs and all of these other things, or all of the planets before they know about their body. And I think it's about planting that seed early on and not using ridiculous terminology to explain things because of our own feelings about terminology or taboos. It's about teaching basic biology to individuals so they understand. The amount of men who say to me, oh, I'm way too old to be learning this for the first time, but a lot of things make sense to me now. And I think we underestimate our ability to understand things from an early age. So we assume that kids are too young to understand things about reproductive health because we've sexualized them and said, well, pregnancy means somebody had sex. Instead of saying, actually, you could easily start with saying there's a sperm and an egg, and when they come together, and we have a monthly cycle because we have this incredible potential as human beings to create life. Instead, we diminish almost every facet of female reproductive anatomy. And there's an incredible medical anthropologist who wrote a paper where they looked at the language that is even used in medical textbooks to really, you just see this huge disparity in the differences. They say, this abundance of sperm in the ejaculate, but women only have one egg. And the menstrual effluent or waste that we produce, rather than saying, actually, we have got this one egg, which is the largest cell in the body, and that sperm need an abundance of them because the majority are actually not ineffective. 60 million of them are needed just for one of them to get in. And it's the smallest cell in the body. And it's really like, maybe we could reframe the narrative to say which one of the genders has a much more powerful role here. But that is systemic across even medical literature. So it's almost like this underlying tone that is set to really put women on the back foot instead of saying, even then saying, she had a baby. What? She grew a life and nurtured it and fed it. I mean, it's almost surreal to think what our bodies are capable of, and yet we paint pictures of pregnant women as out of breath, sweating, and awkwardly, bumbling
Can't tie
around.
the shoes.
Exactly.
Yeah.
So, I think we need a rebrand when it comes to reproduction and our abilities.
100%. And I think that point about using the right terminology, right? Like, it's only really in the last couple of years that we've seen an increase in people using the word vulva and not just vagina for one catch-all thing. Like, imagine if we didn't use separate words for penis and testicles. Like, it was just everything is the penis. Like, it would be a really peculiar thing to use this catch-all phrase to underrepresent the complexity of the pieces. We're running short on time, so I would love that anyone who's got extra questions, obviously, will be around. Come and flag any of us down in the break. But just closing remarks, really. I'd love to know what's next. What kind of, if you could wave a magic wand and we all wake up in 5 years' time and this situation has magically transformed, what's the thing? Tatiana, I'll go to you first.
So to my point earlier, I think less fragmentation in women's health and a more broader understanding, education about women's health, and a more holistic platforms appearing, addressing kind of women's health across the whole cycle, rather than just considering her as baby producing machine.
For me, it would be a shift from this idea of working with the diverse to within diversity. Whenever two people are engaging with each other over a technical platform or face-to-face, both people are within that diversity, rather than one person being the mainstream and then the other person being the diverse. I think what that would then do is it would make both people in the conversation equal, and it would shift from this idea that you have to have a certain characteristic to be effective in the field that you want to make change. I've got a young family member who is so passionate about becoming a vet and never uses her own humanity to invalidate her wanting to work with animals. And it's exactly the same principle. We do not need to embody a certain characteristic in order to help those that do embody a certain characteristic. That shift from with diversity to within diversity will empower everyone in this space to be able to make changes in the women's health space, in the race and ethnicity space, and then the intersection between the two.
Well done.
Thank you.
Yeah. Yes, exactly. For me, it's about opening up the opportunity to use data for good. I think data over the last few years has become a dirty word, synonymous with Meta and Facebook and advertising use of data, as opposed to healthcare data, which should be under a completely different classification, whereby all of us together can really, within a short amount of time, transform digital solutions. We are a digital world, that we can transform healthcare solutions through participation and engagement. And I think that for me is, I was once told when I was furiously, in a positive way, trying to say about all of the different subcategories of women's health. Can we please address all of these different areas, not just women's health as abroad? And somebody said, well, we can't boil the ocean. Mm-hmm. And I just thought, yeah, we can. Of all of us, everywhere, representing, why not? So I think even with us in a small amount of time using our data for good, we could put the ocean on fire.
My vision would be that women and girls are listened to, regardless of whatever it is that the medical practitioner may think, that they give women and girls the space to express their needs and they're actually listened to. Because a lot of the times we hear, the NHS doesn't have money, we can't invest in the space, etc., etc. But listening to people is free, and it can actually save a lot of money in the long term. So that's my vision.
So thank you so much, everybody, for listening to today's panel discussion. As I said, I'm Liz from Medico Digital. There's a couple of us here today. We're over at stand H9, which is like right in the entrance where you came through. If you want to find us, we're at medicodigital.co.uk, and we just launched a podcast. So if you want more of this while you're driving, cooking, etc., then you can listen to me chat about interesting stuff with interesting people. Thank you very much.